Welcome back to Advances in the Management of Renal Cell Carcinoma, presented by the Albert Einstein College of Medicine of Yeshiva University and OMED Live. You're tuned into today's second session titled Strategies for Minimizing Toxicities in Patients Undergoing Treatment for Renal Cell Carcinoma. My name is Dr. Sumanta Kumar Pal, and I'm Assistant Professor in the Department of Medical Oncology and Therapeutics Research and co-director of the Kidney Cancer Program at City of Hope. For those of you just joining, today's session is a live interactive program that allows me to take questions in real time through this presentation. I encourage you to send me questions anytime by typing them in the box located in the lower left-hand side of your screen. So let's go ahead and get started. Now here's my title slide, Strategies for Minimizing Toxicity in Patients Undergoing Treatment for Renal Cell Carcinoma. I really wanted to break down the talk as follows, and you see in this tree diagram here that we're going to start by discussing the major toxicities encountered with therapies that we're using today for kidney cancer, and I also wanted to take a leap ahead and discuss some of the toxicities we might see with some of the agents that are emerging for the disease. In the second portion of the talk, we'll focus on whether or not there are any biological predictors of toxicity, and then we'll move on to discuss whether or not we might be able to prevent and potentially treat these toxicities, and that might constitute the bulk of this presentation. And we'll also discuss in which settings toxicities might be most relevant. In the latter portion of this talk, I'd like to jump to whether or not there are certain toxicities that are associated with response. It's really a fascinating science in kidney cancer. And finally, I'd like to discuss whether or not dose adjustment based on toxicity can really be used to optimize therapy. So again, we're going to start on this next slide by discussing what the major toxicities encountered are. And I just wanted to provide some framework. You're going to hear a lot about therapeutic advances in kidney cancer through the other sessions provided at OMED Live, but I did want to discuss the landscape not too long ago. The only treatment that we really had at our disposal was immunotherapy, and interferon alpha really served as a benchmark for treatment. The meta-analysis that I've shown here included 6 prospective studies of interferon alpha, and the time to progression across those 6 studies was a meager 4.5 months. Median survival a decade ago for kidney cancer was just over 1 year. And it was really on the basis of this data that Dr. Mtor and colleagues suggested that progression-free and overall survival could be compared with interferon alpha in subsequent phase 3 trials. Now, if we jump ahead to the next slide, I wanted to discuss what really has changed in the context of kidney cancer, and it really is our understanding of the biology of the disease. We know that clear cell kidney cancer in particular is driven by angiogenesis. We know that VHL is mutated somatically in about 50% of sporadic tumors. We know that VHL is hypermethylated in 10 to 20% of sporadic tumors. And these aberrations in VHL really lead to dysregulation of a moiety called hypoxia-inducible factor. Hypoxia-inducible factor in turn promotes transcription of mRNA for a molecule called vascular endothelial growth factor, or VEGF. And in fact, the bulk of therapies that we have available today are really targeting VEGF. So I wanted to introduce this slide to suggest what we're doing in the field of kidney cancer. There are a whole host of potentially relevant pathways: fibroblast growth factor receptor, FGFR, the MET receptor, which we'll actually discuss to some extent today. The ERB family of receptors, highly relevant in breast cancer and lung cancer. But really the focus in kidney cancer is what I've highlighted here in red, and those are the VEGF-related signaling pathway elements. So we have agents such as bevacizumab that work upstream of the VEGF receptor to target the VEGF ligand. We have several agents, sunitinib, sorafenib, pazopanib, and axitinib, that are now FDA approved, and these all target the tyrosine kinase domain of the VEGF receptor. And downstream, we have agents that target Mtor, agents such as temsirolimus and everolimus. And what I'd like to do is give you a brief overview of the toxicities associated with these currently FDA-approved agents. And we'll start with the VEGF inhibitors. I always like to refer to this diagram. It really provides a very nice summary of what we might anticipate as class effects from the VEGF-directed therapies. Certainly, when we discuss targeted therapies with patients, we suggest that these are perhaps a little bit more tumor-specific or tumor-tropic and may spare patients of side effects, but it's important to recognize that all of these agents do have substantial toxicities. These can include, for instance, compromised wound healing and tissue repair, hypertension, arterial-thrombotic events, cardiac dysfunction, and proteinuria. And you can really see the mechanism of action for all of these. For instance, the compromised wound healing is by virtue of these agents impeding angiogenesis. This may also play into the agents causing hypertension. We know that these agents can affect vascular tone, causing the potential for proteinuria and cardiac dysfunction. So a whole host of mechanistic reasons for which we encounter these side effects. And rather than going through every single VEGF-directed agent that's currently approved, and as you know, there are 5 total, I thought I'd pick 1 or 2 of these agents and discuss the side effects that we incur. And I'm going to start with sunitinib. As you're probably already familiar, sunitinib is an oral TKI that inhibits vascular endothelial growth factor. It has a fairly wide spectrum of activity. It also targets other moieties at the cell surface, such as platelet-derived growth factor. Sunitinib was assessed in a pivotal trial including 750 patients with previously untreated clear cell renal cell carcinoma. And in that trial, it was demonstrated that there was about a 68% improvement in progression-free survival. And ultimately, we've observed several toxicities. These include diarrhea, fatigue, nausea, and stomatitis, and I would perhaps cite these as being the most prominent. It's also worthwhile highlighting a couple of toxicities that we saw appear on the last mechanistic slide, such as hypertension. We do see that proteinuria also can occur in association with sunitinib therapy. Hand-foot syndrome also stands out as being one of the potentially associated side effects with the drug. And we'll discuss some strategies for combating hypothyroidism, which has also been recognized with sunitinib, as well as the other VEGF-directed agents. In the next slide, I summarize some of the clinical data from sorafenib from the pivotal trial of the agent. Sorafenib is a multikinase inhibitor with affinity for the vascular endothelial growth factor receptor, but also for platelet-derived growth factor, for FLT3, and for c-KIT. And sorafenib was assessed in a 903-patient trial in which patients were either randomized to sorafenib or placebo, and there was an improvement in time to progression and a statistically non-significant improvement in overall survival. But some of the notable toxicities that emerged were, I would say, somewhat similar to sunitinib. We again see fatigue emerge as one of the most prominent side effects. We see diarrhea. We see perhaps a slightly higher rate of hand-foot syndrome in this trial as compared to the last, but nonetheless indicative of class effects associated with these drugs. Now, I did articulate on the previous mechanistic slide the fact that we also target an agent called Mtor, which is downstream from the VEGF receptor. And the schema really emphasizes that. So at the cell surface, we have a variety of moieties: epidermal growth factor receptor, vascular endothelial growth factor. Many of these cell surface receptors actually lead into the PI3K-AKT signaling pathway and ultimately activate Mtor signaling. 2 of the agents that we have at our disposal, temsirolimus and everolimus, abrogate signaling through this pathway. And again, just as we did in the context of the VEGF-directed therapies, I'd like to articulate some of the frequently encountered toxicities that we see with temsirolimus and everolimus. So this slide highlights the data from the pivotal evaluation of temsirolimus. This was a trial that compared temsirolimus to temsirolimus with interferon alpha versus interferon alpha. The study included a total of 626 patients with poor prognosis metastatic renal cell carcinoma. There was an improvement in progression-free survival and also, very importantly, an improvement in overall survival. This trial also highlights an opportunity for us to review some of the side effects associated with Mtor inhibitors. So in terms of the most prominent side effects, asthenia stands out, so does rash and anemia. Stomatitis tends to be one of the more prominent side effects. Some often refer to the Mtor inhibitors as inducing internal medicine disorders such as hyperglycemia, in addition to that, hyperlipidemia. So I always try to engage my primary care community very closely when I start these sorts of therapies. You'll also note that this is the same side effect panel exists for the agent everolimus. Everolimus was assessed in the pivotal RECORD-1 trial, in which it was compared against best supportive care. In this trial, 410 patients with either prior sunitinib and/or sorafenib therapy were randomized, and it was suggested that there was an improvement in progression-free survival. Again, you're going to see some of this clinical data in some of the other presentations today, so I really wanted to use this as an opportunity to highlight the potential toxicities associated with the agent. And again, we see that stomatitis is quite prominent, rash is quite prominent. We see fatigue and asthenias at the top of the list. One thing that I'll point out, which is also true for temsirolimus therapy, and you'll see this at the bottom of the slide, is that there is a risk for dyspnea and pneumonitis in association with the Mtor inhibitors. So one side effect that we really should be quite cognizant of and watch out for when we're treating these patients. And again, with everolimus therapy, not highlighted in this slide, but we do see some non-clinical toxicities and laboratory-based toxicities, such as hyperlipidemia and hyperglycemia. So again, worthwhile engaging your internal medicine colleagues in treating these patients. So I would be remiss not to discuss some of the new agents that are being developed for kidney cancer. And in the next mechanistic slide, what you see is a diagram that outlines